Yeah, shall we start?
Yes, ma'am.
Okay. Hello, everyone. Welcome to Auricle Exam Mastery Live classes. So today we'll be starting with Neuroanatomy. So these mastery classes we have started since June 1st, and it is for a duration for about 30 days. So I'm Dr. Divya, live class educator for Auricle. So in these exam mastery live classes, we will be doing rapid revision of all the important questions and a quick revision of all the volatile facts, as well as we'll cover all the high yielding topics in all the subjects. And the most important topics related to exams will also be covered. So this is beneficial for all the university exams of all the states. You can use the code Dr. Divya 20 for the discount on the subscription. So in today's class, we'll be covering some of the neuroanatomy topics. So before we start, let's know a little bit about Auricle. So the core features of Auricle are we offer you live classes as well as recorded classes so that you can access them anytime, anywhere. We also offer you notes, which are CBME based question and answers, MCQs. And you have a fun zone also, like where you can do a self-assessment and enjoy it. So these MCQs are from the beginner level and up to the expert level. They're all standard multiple choice questions, which are frequently asked in the exams. So we have three subscription plans: the basic, standard, and the mentorship. Mentorship is a person program for a year, and we offer you at a special rate of 50,000. And here, including the other services and other subscription plans, we also give you one-to-one personalized guidance as well as notes. So you can use the code Dr. Divya 20 for the discount on subscription. You can also book a slot for personalized counseling session too. So we shall begin with today's class. So first, coming to the vertebral canal. So it is an elongated cavity which we see inside the vertebral column. So this vertebral column, we all know that it has 33 vertebrae. Okay, it's made up of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, and 5 sacral and 4 coccygeal. So each vertebrae will have ventrally a body and a dorsally a ventral arch. Okay, dorsal we have a vertebral arch. So these two enclose the body, and the vertebral arch will be enclosing the vertebral foramen. So the structure of the vertebral canal, so it is a smooth walled space anteriorly bounded by the vertebral body and intervertebral disc, and posteriorly there is the longitudinal ligament. So and we also have, the intervertebral disc and the posterior longitudinal ligament are present anteriorly, and the posteriorly it is bound by the posterior, what do we mean by posterior longitudinal ligament is, on the inner surface of the body of the vertebrae, we will have a ligament, okay? So on the outer surface towards the ventral side, we call it as the anterior, and towards the inner side, that is the posterior part of the body, we call it as the posterior longitudinal ligament. So posteriorly, the vertebral column is bounded by the vertebral lamina and the ligamentum flavum. So this vertebral canal will be continuous above with the cranial cavity and below with the sacral canal. So what do we have within the vertebral canal? So there is an epidural space that is around the dura mater, that is the meningeal layer. And we have the spinal meninges, and within that we have the spinal cord with the nerve roots. So these are the main contents there. This blood supply of the epidural space here, epidural space is separated from the spinal meninges. Okay. Basically, this the epidural space is space between the vertebral column and the spinal meninges. Okay, that is the meningeal layer of the dura mater. So in the spinal cord, okay, the meningeal layers, usually we have three meningeal layers, right? We have the dura mater, the arachnoid, and the pia mater. So dura mater consists of two layers in the cranial cavity. That is the outer dura and the inner meningeal layer. Okay. Here that is the endosteal layer. Outer dural layer will be the endosteal layer and the meningeal layer. But in the vertebral column, we do not see the endosteal layer. We see only the meningeal layer. Okay. And why we do not see the endosteal layer is because the endosteal layer in the cranial cavity will be lining the cranial surface, that is the bony cavity, right? But in the vertebral column, if it covers, what happens is the vertebral column cannot be flexible. We move the vertebral column for side-to-side bending, forward bending, flexing, extension, and all. We use the spinal cord, right? The vertebral column. So the vertebral column, if the endosteal layer is present there, it cannot, and the endosteal layer can tear. So that is why endosteal layer is not present there. Okay, only the meningeal layer is present. So between that meningeal layer and the vertebral column, that space we call it as the epidural space. So the spinal artery supply the spinal cord, okay, the nerve roots and the surrounding structures. The internal vertebral venous plexus, okay, they will be draining the venous blood from the vertebrae, spinal meninges, and the spinal cord. So external vertebral venous plexus lies outside the vertebral column and they communicate with this internal vertebral plexus. Okay, so they will be connected. So the veins here, they lack valves and there will be bidirectional flow. So internal vertebral plexus, they act as venous bypass, and they help manage the sudden increase in intra-abdominal pressure. So pelvic tumors like prostate cancer can spread to the vertebral bodies without passing through the heart and lungs. Okay, so through these vertebral plexus, it can reach to the vertebral bodies. So case history here. So Mr. Rajkumar, a 58-year-old Indian male, presented with worsening lower back pain and difficulty walking. He had a history of prostate cancer diagnosed 2 years ago, treated with radiation therapy, and his recent imaging reveals metastasis to the vertebral body. So what is the likely reason for Mr. Rajkumar's lower back pain? So here if you see, here he has lower back pain, difficulty in walking, and there is a history of prostate cancer, right? So the cause is related to the metastasis of prostate cancer to the vertebral bodies. So in case of pelvic tumors, especially the prostate cancer, what happens? The internal vertebral venous plexus can act as venous bypass. Okay, so basically the blood doesn't go to the heart. Instead, before that, it passes through these veins, okay, the vertebral venous plexus, managing sudden increase in intra-abdominal pressure. So the metastatic spread from the pelvic tumor, okay, so the metastasis basically may use this venous bypass, reaching the vertebral bodies directly, okay, without passing through the heart and lungs. So this is the reason for his lower back ache. Now coming to the spinal cord. So spinal cord is a very important discussion topic, can be asked as a 5-marker question, okay, and part of it can be asked as 3 markers too. So here spinal cord, it is a lower elongated part of the central nervous system. Okay, so it is cylindrically in shape. It is flattened slightly flattened anteroposteriorly. It occupies the upper 2/3 of the vertebral canal. So what are its characteristic features? It measures about 45 centimeters, that is about 18 inches in adult males, 42 centimeters in adult females, and weighs about 30 grams. It extends as a downward continuation of the medulla oblongata from the upper border of the posterior arch of the first cervical vertebrae. Okay, so from there it extends to the lower border of the first lumbar vertebrae. So the lower tapering extremity, okay, tapering extremity, we call it as the conus medullaris. Apex of the conus medullaris, okay, has got a downward, it continues downward as a thin thread-like filament called as phylum terminale. It provides attachment to 31 pairs of spinal nerves connecting to tissues of the trunk, girdles, limbs, and the viscera. So what are the functions of the spinal cord? It executes the spinal reflexes. So main thing is that spinal reflexes. It transmits the impulses to and from the brain. So positional changes. So here, the thing is the level of the spinal cord differs according to the age also. So what happens is in the intrauterine life, the spinal cord extends entire length of the vertebral column because both the growth will be occurring simultaneously. But later on, what happens? The vertebral column goes faster than the spinal cord. Okay. So because of that, the terminal end of the spinal cord shifts to a higher level. So the spinal cord at birth, the spinal cord will be ending at the L3 vertebrae, while in adults, it terminates at the lower border of L1. So this variation is very important because when we do lumbar puncture in children and adults, it varies, okay? The level varies so as to avoid injury to the spinal cord. So you can see here in the intrauterine life, it is the entire length of the vertebral column. So at birth, it shifts to the lower border of L3 and later on, okay, it shifts to the lower border of L1. So this portion tapering end, we call it as the conus medullaris. Okay, and this one is the thin part is the phylum terminal. Okay, so how describe? So question can be asked as describe the spinal cord under the following extent and coverings. So external features and enlargements, cross section at mid thoracic level, blood supply and applied aspects. Okay. So when like that, when the question is asked, each part you have to answer. So here, extent. Okay, so extent, it is from the foramen magnum to the lower border of the second sacral vertebrae. Okay, from the foramen magnum to the up to the lower border is the extent of the sacral vertebrae. Okay, is the extent. Coverings is dura mater, arachnoid mater, pia mater. Okay, why we are saying to the lower border of second sacral vertebrae, it's not exactly the spinal cord which extends till there. It is spinal cord will be extending only up to the level of L1. Okay, here what is meant is the meningeal extensions. Okay, it is not the spinal cord extent. Coverings is dura mater, arachnoid mater, and the pia mater. Spaces, we have the epidural space between the spinal dura and the vertebral canal. As I told you earlier, the meningeal layer of the spinal cord as well as the vertebral canal. That space is the epidural space. Then there is subdural space between the dura and the arachnoid, and subarachnoid space below the pia mater and the arachnoid. Okay, so this is filled. The subarachnoid space is filled with the CSF. So you can see here. Okay. This is the subarachnoid space, which is filled with the CSF. So external features. So the diameter and extent, it is roughly cylindrical with an average diameter of about 1.25 centimeters. So it has two fusiform swellings. Okay, one is the cervical enlargement for extending from C3 to T1 level. So basically it is formed because of the C3 to T1, all of us know, contribute to the formation of basically from C4 to T1 contributes to the formation of the brachial plexus. Okay, and the lumbar enlargement T9 to L1, it is basically the we have the lumbar plexus. Okay, so that is why we have the those enlargements, cervical and the lumbar enlargement. Fissures, it will have an anterior aspect. There is anterior median fissure, and on anterolaterally there is anterolateral sulci. So just okay, and posterior aspect there is posterior median sulcus, and posterior lateral and posterior intermediate sulci. Okay. So attachment of the spinal nerves. So there are 31 pairs which emerge from the side of the cord. So we have cervical, 8 cervical spinal nerves, thoracic is 12, lumbar is 5, sacral 5, and coccygeal is 1. Okay, next important is extensions of the pia mater. So pia mater, which is covering the spinal cord, will have some extensions. Okay, so this is asked as the shortest set question. So first one is phylum terminal. So what is this phylum terminal? It is a thin thread-like extension of the pia mater beyond the conus medullaris. Okay, conus medullaris. Conus medullaris will be extending till the level of L1 or L3. Okay, so length is about 20 centimeters from the tip of the conus medullaris Okay, so from the tip of the conus medullaris up to the coccyx, it is about 20 centimeter. So it pierces the dural tube, that is the outer dura mater, it will pierce and it passes through the sacral canal and exits through the sacral hiatus. Okay, it passes through the sacral canal and it will exit through the sacral hiatus. So divisions are, we have two divisions of the phylum terminal internal and phylum terminal external. Okay, or it's also called as phylum terminal interna and externa. So this phylum terminal interna, what do we mean by that? That initial 15 centimeters of this phylum terminal, it lies within the dural sac. Okay, that is the meningeal layer of the spinal matter, meningeal layer of the dura mater, which is covering the spinal cord. Okay, and phylum external, this is about 5 centimeters. It will be lying outside the meningeal layer of the dura mater. Then we have ligamentum denticulatum. This is very important clinically also. So it is narrow ribbon-like bands formed by the pia mater between the dorsal and ventral nerve roots on each side. Okay, so there are dorsal and ventral nerve roots. So between that we see this ligamentum denticulatum. Okay, so what does this do? It is like teeth-like projections. Okay, so corresponds to the vertebrae there. So there are 21 on each side and they pass through the subarachnoid space. So function is it anchors the spinal cord to the middle of the subarachnoid space and it also extends from the foramen magnum level between the L2 or T12 and L1 spinal nerves. Then we have linea splendens. So linea splendens, it is the thickened band of pia mater along the anterior median fissure. Okay, so between the anterior median fissure and the pia mater, we have the this linea splendens. Then subarachnoid septum. Subarachnoid septum is fenestrated pia. This is a pia septum in the mid-sagittal plane. Okay, subarachnoid septum. So subarachnoid septum, to remember easily, like how we have the linea splendens in the anterior median fissure, similarly in the posterior median sulcus, we have the subarachnoid septum. Okay, so it will be connecting the pia mater with the arachnoid mater posteriorly. So attachments posteriorly connected with the posterior median septum of the spinal cord. Okay, so here you can see this is the conus medullaris. From there, the thin extension will be the phylum terminale. This is all the tuft of nerves. These are called as the cauda equina. So enlargement and what is the importance of that? So cervical enlargement extends from C3 to T1. Okay, spinal segments, they are formed by the spinal segment C3 to T1. And vertebral levels, okay, they lie opposite to C3 to T1. So purpose is it supplies the musculature of the upper limbs and the girdles. Okay, lumbar enlargement is T9 to L1. It lies opposite to T9 to L1 and it supplies the musculature of the lower limbs and the girdles. Girdles means pelvic girdle there, whereas that is the pectoral girdle it supplies. Okay. So these enlargements, they are strategically located to accommodate a higher concentration of motor neurons. Okay, basically they are supplying the limb muscles, and limbs we have more bulk of the muscles, right? So they are supplying these muscles. So supplying the muscles means there should be motor neurons. So the cervical enlargement is for the upper limb, whereas the lumbar enlargement is for the lower limb. So difference between the spinal and the cranial dura. So spinal dura, so as I said earlier, it consists only of a single layer, that is the meningeal layer only. Whereas the cranial dura, it consists of an inner meningeal and an outer endosteal layer. And it does not form folds. Here it forms folds, that is the, in the cranial dura, we have the dural folds, right, which houses these dural venous sinuses. We have the falx cerebri, the falx cerebelli, tentorium cerebelli, and diaphragma cellae. Here epidural space is present. Epidural space is outside that dura mater, the meningeal layer and the vertebral column. But here it is absent because the endosteal layer is present there and it is firmly adherent to the inner layer of the cranial cavity. Now, cauda equina. So what is cauda equina now? So it is due to the shorter length of the spinal cord compared to the vertebral column, spinal nerve roots, they exhibit an increase in both length and the obliquity. Okay, so because the spinal cord is ending where? In adults at the lower border of L1. But the nerves have to supply up to S5 and coccyx, everything, right? That region. So the nerves which are coming down from the above spinal segments of the corresponding final segments, they form a tuft of nerves together, which looks like the tail of the horse. Cauda is the tail portion. Okay, equina is horses. Okay. Right. So the progressive change allows the spinal nerves to emerge through their respective intervertebral foramen. So the nerve roots of the lumbar, sacral, and coccygeal nerves originating from the caudal part of the that is the spinal cord takes a more vertical course. So these nerve roots form a bundle or leash of nerve fibers along the filum terminale, and they are known as the cauda equina. The cauda equina comprises the roots of the lower 4 pairs of lumbar, 5 pairs of sacral, and 1 pair of coccygeal nerves. So that is what is present in the cauda equina. Okay, the lower 4 pairs of lumbar, then sacral, and 1 pair of coccygeal nerves. So here you can see this is the cauda equina. So blood supply of the spinal cord, it is very important, blood supply of the spinal cord. So it is supplied by mainly the spinal arteries, anterior spinal and a pair of posterior spinal arteries. And it is reinforced by the segmental arteries. Okay. So we will see what are those. So anterior spinal artery, it is formed by the union of small spinal branches from the right and left vertebral arteries. Okay, so right and vertebral arteries in the upper cervix. So instead of the blood supply going from down to up, no, it comes from upwards to downwards. Okay, so the right and left vertebral arteries, they join together. Okay, in the upper cervical region. So there they join. So from there it extends, runs caudally in the anterior median fissure. So it terminates along the filum terminale and supplies the anterior 2/3 of the spinal cord. Then there are 2 posterior spinal arteries. Okay, 2 posterior spinal arteries. So these are the branches from the vertebral or posterior inferior cerebellar arteries. So it runs down on the posterolateral aspect of the cord. Okay, it is in the posterior. So it is just single, no? So it runs in the there are in pairs. Which one? The posterior spinal arteries in pairs. So they run down along the posterolateral. Instead of the posterior median sulcus, they run along the posterolateral aspect of the cord. So it divides into collateral arteries along the medial and lateral sides of the posterior nerve roots. Okay, and they supply the posterior 1/3 of the spinal cord. Then we have segmental arteries. So segmental arteries are nothing but the spinal branches of deep cervical, ascending cervical, posterior intercostal, lumbar, and lateral sacral arteries. Okay. So these will be the segmental arteries, which will be forming a circle there. We will come to that. Okay. So they reach the spinal cord as anterior and posterior radicular arteries along the corresponding roots of the spinal nerves, and they nourish the nerve roots. So it forms 5 longitudinal arterial trunks. Then we have pile plexus, which is called as the arteriae coronae. So the formation is basically by the communications around the cord by reinforcement of the segmental arteries. So basically the spinal arteries and the segmental arteries, they reinforce to supply the spinal cord, and they form kind of plexus or arteria coronae, okay, around it. So peripheral branches, they'll be supplying the superficial regions of the cord. Then we have anterior radicular arteries. So they are larger but few in number than posterior radicular arteries. They reach the spinal cord to reinforce the anterior spinal artery. Then we have arteria radicularis magna. So this is it is actually large at the 11th thoracic. Okay, segmental level. Okay. So this articularis radicularis magnus. So it is also known as artery of Adamski-Wick. The venous channel of the spinal cord. So here, no, the venous blood is drained by two median longitudinal sulcus. Okay, so anterior and posterior. Then two anterolateral veins, that is in the anterolateral sulcus, and two posterolateral veins in the posterolateral sulcus. So they communicate with the internal vertebral venous plexus. So how do they drain? They drain through the intervertebral foramen to drain into the vertebral, posterior intercostal, lumbar, and lateral sacral veins. And it also drains into internal vertebral venous plexus. Okay. And this internal vertebral plexus will be actually communicating within the cranial cavity with the basilar venous plexus. So that is how the cancer metastasis can spread. Okay, so this is how the arteries will be present and forming the corona radiata. Okay, this is the corona radiata. 20-year, so we'll see some MCQ questions. A 20-year-old patient present with persistent headaches and neurological symptoms. So the medical team, they decided to perform a lumbar puncture for diagnostic purposes. So which is the most suitable interspinous space for this procedure? So what is the age now here? Is not a small child, is a 20-year-old patient. Okay, so we need to do lumbar puncture. Okay, so what do we need to remember? We need to remember the extent, right? So it is extending from the C1 arch up to the lower border of L1. So where will we do? We do the below that we will do. Okay, so it will, we take the space between L3 and L4. Where it ends, the two spaces below that we take. Okay, so L3 and L4. So reasoning is what? Because a lumbar puncture is typically performed in the lumbar region. So below the termination of the spinal cord. So the interspinous space between L3 and L4 is roomy. Why do we prefer that? One is we do not cause any injury, and second thing is it is more spacious because the spinal cord is not there. It is only those nerves that we have the phylum terminal and the extensions of the piamat, right? So that is what is there. So so this region, it basically contains, as the saying, phylum terminal and the nerve roots forming the cauda equina, and they maximize the risk of spinal cord damage. Okay, and next thing why we do is the horizontal line through the highest point of the iliac crest passes over the spine of the fourth lumbar vertebrae, making the interspinal space between L3 and L4 a reliable landmark for the lumbar puncture. Okay, so basically performing the lumbar puncture in the interspinal space between L3 and L4, it will facilitate a successful procedure with very minimal risk, allowing for the collection of CSF for diagnostic analysis. Next case, 45-year-old patient presented with a sudden onset of lower back pain, weakness in the legs, and difficulty controlling bowel and bladder functions. Okay, this is a very important fact. On examination, there is loss of sensations in the saddle area. What is likely cause of these symptoms? Okay, so lumbar strain, sciatica, cauda equina syndrome, and herniated cervical disc. So which one is the answer? Cauda equina syndrome. Okay, so cauda equina syndrome, it results from the compression of the cauda equina, which involves the sacral nerve roots. So the clinical features, they include lower back pain, weakness in the legs, saddle-shaped anesthesia also. That is basically the saddle-shaped anesthesia is, you have seen the saddle on the horse, right? They keep the saddle for the horse riders to sit. So that portion comes in contact with the perianal region. Okay. So that is why we call it as the when there is weakness in that region, okay, We call it as the saddle-shaped anesthesia. So, and there is severe root pain and lateral urinary and bowel retention. Okay. Then the syndrome is often occurs due to conditions like extradural tumor, prolapsed intervertebral disc, as well as spinal cord stenosis. And when the paralysis occurs, it is usually lower motor neuron type of paralysis with areflexia. Okay, so recognize the symptoms of cauda equina syndrome is very crucial. Why? For the prompt intervention and preventing permanent neurological damage. So urgent evaluation and management, it involving the surgical intervention are necessary in suspected cases of cauda equina syndrome. Coming to the internal structure of the spinal cord, okay, so the composition here, see basically the central nervous system, entire central nervous system has got white matter and the gray matter, right? So the gray matter usually are what? The neurons, the dendritic processes, neuroglial cells, and maybe a few blood vessels maybe. White matter basically consists of myelinated or unmyelinated processes. Then supporting cells, that is neuroglia, and the blood vessels. Bilateral. So bilateral symmetry now. So when we say, what do we mean by bilateral symmetry? So the gray matter, okay, it will have a butterfly shaped. Okay, so in the center, there is a butterfly. It will have a posterior horn. It will have an anterior horn. And sometimes in the thoracolumbar region, you may see the, that is lateral horn too. Okay, that would basically see in the thoracic and the lumbar. So, yeah. So cross-sectional area. So cross-sectional area, so the largest gray matter area, which is in the center. So mid to the lower thoracic and mid to lower lumbar level. So it is the largest there. Okay, mid to low cervical and mid to lower lumbar levels. So the least gray matter area is the thoracic level. So white matter areas, they are greatest at the cervical. Okay, so large amount of white matter is present more at the cervical, and it is least at the sacral. Okay. So what is the orientation of the neuronal processes? Neuronal processes are basically the axons there. No? So white matter, they are parallel to the longitudinal axis. Gray matter is basically perpendicular to the long axis. Okay. So gray matter structure. So it is subdivided into three parts: ventral, dorsal, and lateral columns. Columns means basically in the central nervous system, instead of nerves. So see, collection of the axons outside the central nervous system, we call it as the peripheral nerve. Okay. Whereas inside the central nervous system, we call it those axons collection. We call them as tracts. We call them as fasciculars. We call them as lemnisci. We can also call them as columns too. So gray matter contains butterfly wings, that is central with the central canal within it. Okay, so what are the columns in the gray matter? We have the dorsal, which is otherwise called posterior, ventral, anterior, and lateral. Okay, lateral is the intermediolateral part. Okay, which I told you, it can show the thing. Where the gray matter can show a horn. Similarly, in that related area, we call it as the lateral. So this is present from T1 to L2, L3. Also termed anterior, posterior, and lateral horns in the cross section. Then there is reticular formation. Reticular formation is basically the network of nuclei and nerves. Okay, so nerve fibers that is present there. So they are seen in the basically in the lower cervical. Okay, cervical levels between the anterior gray column and the white matter. Then central canal. So central canal, it is lined by the ependymal cells, which is surrounded by the substantia gelatinosa. So this central canal is very important because that there in the central canal will be the CSF. Okay. Next, the structure of the neuronal there or neuronal architecture. So here, the processes will form an intricate network, okay, of unipolar neurons, motor neurons, and crossing axons. So multipolar neurons, they are organized in the, so where they are present mainly in the dorsal, lateral, and the ventral columns. Then you should know what do we mean by rexed lamellae. Rexed lamellae here, they are organized gray matter into 9 layers plus central canal region. So it is named after Swedish neuroanatomist Rext. So what are the characteristic features of the spinal segments here? Okay, which are as seen is the transverse sections at various. So different levels when we take a section, whether it may be cervical level or it may be the thoracic or cervical asset, so thoracic or the lumbar or the sacral region. Okay, so we take a different sections and see. So what will be the main features there now? So outline of the section, okay, how it looks on the outline. So in the cervical, it is oval. Thoracic, it is oval to circular. Lumbar, it is mainly circular, okay. And in sacral, it may be circular or quadrilateral. It's very bigger segment in the sacral. Okay, sacral segments are basically larger. So gray matter here, the cervical is large, thoracic is small, and lumbar is large. The sacral also, it will be relatively large. Posterior horn will be slender and extends from posteriorly. In thoracic also, it is slender. And yeah, and in the lumbar region, the posterior horn becomes bulbous, as well as in the sacral. Sacral also, it looks very massive, okay? Then the lateral horn. Lateral horn here in the cervical. Okay. Lateral horn in the cervical is massive, thoracic it is slender, and in the lumbar region it is bulbous, and in the sacral it is massive. The anterior horn, here actually there is a small mistake here. Okay, so anterior horn will be larger here, and this lateral horn is absent in case of cervical. Thoracic, lateral horn can be present, and the anterior horn is slender. Okay, and here in the lumbar region, it is present. Okay, so in the L1 and L2 segments. Okay, and in this sacral, here it is present in the, that is S2, S3 and S4 segments. Reticular formation is well developed both in cervical and thoracic, and it is absent in the lumbar and sacral regions. So the amount of white matter now, okay, so amount of what we were talking, anterior horn, lateral horn, they were all the gray matter. So amount of white matter, it is very much, okay, massive, okay, 4+ in the cervical. Then it is larger. This is less larger, okay, less size. That is, the amount of white matter is less there compared to the thoracic. And the sacral is very less amount is there. So posterior intermediate sulcus. Okay, so posterior intermediate sulcus, it is present all throughout the central nervous system. That is the brain as well as the midbrain. So it is present throughout. So thoracic, it is present in upper cervical thoracic segments. Sorry, I mentioned wrong here. So posterior intermediate sulcus, so it is present throughout the entire length of the spinal cord. Okay, so cervical, thoracic, lumbar, and sacral. The thoracic, it is in the thoracic part, it is present in the upper 7 thoracic segments, but here in the lumbar, it is absent. And in the sacral, it is also absent. So basically, the posterior intermediate sulcus, we can see it in the cervical, in the upper 7 thoracic segments. So the nerve groups. So this is important, the nerve groups. Okay, so in the there is a dorsomarginal nucleus. Okay, dorsomarginal nucleus. So in the rex lamina, it is lamina 1. So it extends lengthwise. So it caps the dorsal horn and it receives. So What does it receive? It receives the pain, temperature, and light touch sensations. Then there is substantia gelatinosa. So it will extend entire length. Okay, so dorsomarginal nucleus. These are all the nucleus in the posterior horn. So this also extends lengthwise and it is packed with Golgi type 2 neurons and it receives the sensory input from the dorsal root ganglia. Okay, so this also carries the sensations, sensations of pain, temperature, and light touch. I relate there. Okay. Then we have nucleus proprius. So nucleus proprius we see in lamina 3 and 4. So it extends lengthwise. It is densely clustered. Okay, densely clustered and large nerve cell bodies which are ventral to the substantia gelatinosa. So it receives the central processes of unipolar neurons. Okay, it receives the central processes of the unipolar neurons for pain, light touch, and temperature. That is the nucleus proprius. Then we have nucleus dorsalis. Okay, that is the Clark's column we call. So it belongs to lamina 7. So it extends from C8. So this we see it from the cervical, 8th cervical to 3rd lumbar. It is located at the base of the dorsal gray column. It houses large cell bodies receiving the synapses for proprioceptive fibers. And it sends axons in the dorsal spinocerebellar tracts. Then we have the lateral nucleus. The lateral nucleus belongs to lamina, again 7. So it is composed of small multipolar cell bodies of preganglionic sympathetic neurons. Okay, so it presents from T1 to L2, L3. Okay, and it sends axons to sympathetic trunk via the white rami communicants. Then we have the sacral parasympathetic nucleus, lamina 7. It is located at the sacral levels, so 2 to 4. Then preganglionic neurons for sacral outflow of the parasympathetic. Okay, so basically it has the preganglionic neurons for sacral outflow of the parasympathetic nervous system. Medial group belongs to lamina 9. So it extends the entire length except for L5 and S1. So it is subdivided into 2 groups, okay? Dorsomedial and the ventromedial groups. So from there, the muscles of the abdomen, intercostal muscles and neck are drained. They are carrying basically the motor fibers, okay? So the muscles of the abdomen, intercostal muscles and the neck. Okay, then the central group is lamina number 9 again. So it is the smallest. So it presents in only, we can see the central group only in the cervical and lumbosacral segments. And it includes phrenic nucleus, which supplies the diaphragm, accessory nucleus to the sternocleidomastoid and the trapezius, and lumbosacral group. Okay, for group function. Okay, so basically it involves the lumbosacral, so L2 to S2. So the function here is not known. Lateral group is lamina number 9. It is present in regions which are responsible for the upper, that is the motor innervation of upper and lower extremities. That is C4 to T1 and L2 to S3. Okay, so this is how you see. Substantia gelatinosa, nucleus proprius. Okay. Then we have, this is the Clark's nucleus and this is the visceral afferent nucleus. Okay, this is the intermediate group. So you can see the intermediate here, intermedial mediolateral and intermedial nucleus. Yeah. So for that is basically for the sympathetic and the parasympathetic. Okay. And in the anterior horn, we have the lateral group, the central group and the medial group. So your white matter composition is bilaterally symmetrical here. Now after gray matter, now we go to the white matter. White matter on the outside, it is bilaterally symmetrical and it has both myelinated and unmyelinated nerve fibers. So the functions of the white matter, it brings information to into the central nervous system and transmits it to the higher levels, right? We know that is the function there. And it transmits information from higher levels to the spinal cord, muscles and glands from there. So now we should know which are the major columns. Columns is basically those tracts. One is the dorsal funiculus, which is present between the dorsal median and dorsolateral sulci. Okay, dorsal median and dorsolateral sulci. So here it has the medial fasciculus gracilis and there is laterally fasciculus cuneatus. So basically they are the tracts. And they are the tracts basically for which one, the gracilis and the cuneatus, they are responsible for the joint sensations, vibration, 2-point discrimination. Okay, so they are responsible for that. And we see them in the cervical and upper thoracic aspects. So lateral funiculus is between the dorsolateral and the ventrolateral sulci, and the ventral funiculus is between the ventrolateral sulcus and ventral median fissure. Subdivisions. Now, this dorsal funiculus is subdivided into medial fasciculus gracilis and lateral fasciculus cuneatus. The ventral funiculus has the ventral wide commissure, the region of decussation for the spinothalamic tracts. Okay. Then within the funiculi, which are the tracts now? So tracts and fasciculi or funiculus all means the same only. Okay, this is in the central nervous system. Only outside the central nervous system, we call it as the peripheral nerve. So here the tracts, they are well defined with clear boundaries, and only few of them will have the overlapping boundaries. Most of them will have, overlapping boundaries. So what are the three types of tracts we see? We see the ascending tracts, descending tracts, and intersegmental tracts. Ascending is going up, right? So they're basically carrying the sensory information, whereas the descending tracts, they relay the motor information, and intersegmental tracts, they convey information between the spinal segments as well as the coordinating the intersegmental spinal reflexes. So where is this ventral wide commissure located and what is its function? Okay, this is a MCQ question. Ventral wide commissure and what is its function? So the choices they have given is there in the dorsal funiculus relaying sensory information, in the ventral funiculus which houses the motor neurons, then in the lateral funiculus which coordinates the reflexes, or in the central canal which regulates the cerebrospinal fluid flow. So this thing is, where is the ventral wide commissure? So the ventral wide commissure is in the ventral funiculus, okay? So basically at the region of the decussation of the spinothalamic tracts. So option B is correct. So what does the lateral funiculus lie between? Dorsal lateral funiculus, okay? So dorsal and ventral median fissures, dorsal lateral and ventrolateral sulcus, dorsal and ventral funiculus, gray and white matter. Okay, so the lateral funiculus, it lies between the dorsolateral and ventrolateral sulci. Okay, dorsolateral and ventrolateral sulci. Next, a person complains of sharp shooting pain along the lateral aspect of the leg and foot. Which arterial supply is associated with pain sensation in this region of the spinal cord? Which one? So we have anterior spinal artery, posterior spinal artery, segmental artery, and posterior radicular artery. So here the lateral and ventral spinothalamic nerve tract, which involves the pain sensation, involves pain sensation, they receive blood supply from the segmental arteries. So in the case of a large artery in the 11th thoracic level, what term is usually used and which artery does it refer to? One is it called that is the posterior spinal artery, and which is called as the artery of Adam-Kiewick. Then anterior spinal artery, which is otherwise called as the radicularis magna. Then segmental arteries, which is otherwise called as the artery of Adams-Kiewick. And there is radicular artery, which is a branch of anterior spinal artery. Okay. So a large artery at the 11th thoracic vertebrae, we usually call it as the artery of Adam-Kiewick. Okay. So this is where we see it in the supply of the spinal cord. During a lumbar puncture, why is the intraspinal space between L3 and L4 the most preferred site? So why it is? I told you already, intraspinal space between the L3 and L4, because it is quite roomy. Spinal cord is ending above, isn't it? So what are the options they are given? It aligns with the spinal root of the cranial nerve. That is which one? 11th cranial nerve. Spinal root of cranial means that is the accessory nerve. The subarachnoid space is more spacious in this region. Then it allows access to the dorsal funiculus. The central canal is easily acceptable in this area. The interspinal, so what is the explanation? The interspinal space between L3 and L4 is preferred for lumbar puncture because of the more spacious subarachnoid space, which facilitates the purpose. Okay. Okay, so with this, we end the class for today. So thank you all for watching Auricle. Okay, so for more contents, you can follow the social media handles, YouTube, Instagram, Facebook, and Telegram. And if you haven't yet downloaded the app, okay, you can get it on Google Play and as well as on the App Store. So, and you can start your journey with Auricle. Thanks for watching Auricle. So until then, next time.